For people who do manage to survive severe Ebola disease, there are a number of sequelae that are also kind of famous with this disease. Some of those sequelae are chronic fatigue, headaches, arthralgias that can happen, neurological symptoms like memory loss, and also problems with the eyes, uveitis, pain, blurriness, sensitivity in the eyes, photophobia, hearing loss, and all of that, not to skip on Marburg coverage, but copy and paste from Marburg. It's a very similar presentation. You usually cannot clinically distinguish those two diseases based on presentation alone. You would need PCR, or you would need to do serology, paired sera, to see a specific antibody response. Ebola is usually considered to be a little bit more severe than Marburg, but not something you can hang your hat on clinically or rely upon. In terms of those sequelae that I mentioned, this is a really high-profile case in an American doc who went over to assist with the outbreak in West Africa. This is Dr. Ian Crozier, if you've ever heard of this guy. He contracted Ebola. He was working for Emory, and he was on the brink of death. They brought him back to Emory University. He was one of those patients that was medevaced, basically, back to the United States when he got really, really sick. And he was so sick that he was to that point where you have organ failure pretty much, where he was very likely going to die. So he was on mechanical ventilation for almost 2 weeks. He was on hemodialysis because his kidneys failed for 21 days. I put the link to his case study on the slide notes if you want to read about him. But what's so interesting about him is because he's a survivor and because he's an infectious disease doctor, when he recovered, he went on a lecture circuit and started talking about his experiences in a really medically sophisticated way. And he wrote about it. He's an author on his own case report, which is sort of cool, you know. But when he recovered, he talks about what that recovery was like and how long it took, and all of the neurological problems, this fog that he slowly came out of. And then famously, the ocular problems that he had. When he was discharged from Emory, he was PCR negative for Ebola virus in his blood. But then when he developed this really severe uveitis and he had a bunch of other ocular problems that you can read about, they took a specimen, his aqueous humor from his eye, and they ran a PCR on that, and he had Ebola in his eyeball. And they did the similar thing with his semen. They took semen samples, ran a PCR on that, and he had Ebola in his semen as well. So this was, prior to Ian Crozier, not a very well characterized example of an RNA virus that can establish persistence in immune privileged sites, like the eye, like the reproductive organs. But it took him a long time to finally clear virus out of those immune privileged sites. And he was, when he went on the lecture circuit, he came to UVA and lectured when I was a grad student there. He talked about how unpleasant it was, as you can imagine, to have like a needle come in and withdraw vitreous fluid from your eyes and the semen, and then have to go and talk to large audiences about having that done to you. I mean, yeah. So he was a sport about it, good sport. But super interesting guy. Long story, sorry, but he did after that take a job up at NIAID. He was the chief medical officer up at the IRF, the Integrated Research Facility. So I got to work with him a little bit more up in Frederick, and just super interesting person. So if you have time, it's interesting work to read about some of the sequelae that he experienced. The next virus is my favorite, Lassa virus. Very cool little virus. Yeah.
Oh, sorry, just quick about would those fluids still have been considered infectious then, or?
Yeah. Yeah, well, so it's a good question. With PCR, you can't determine whether or not something's viable or not, right? Like if there's viable virus. But with the semen, the only way you can determine whether or not there's infectious virus is to do like a tissue culture assay and see if it's able to infect cells. So you'd send that down to a BSL-4, like USAMRIID or like CDC, and have them do infectivity assays to confirm that it's viable infectious virus. With him, I think they did that. And they definitely told him that he basically has like the mother of all STIs, don't sit with anyone for a while. But he did eventually become PCR negative as well. I was gonna say something else about that, but I'll see if I can remember. Yeah.
How long was he cured for, I guess? Like, how long until he cleared it from his, like, vitreous fluid?
That's a good question. I've wanna say like a couple months of persistence, but, I remember what I was gonna say about that note on persistence. I don't wanna put it in your head that this is a persistent virus, but one thing that happened when it ripped through that many people, like tens of thousands of people during the 2014-2016 outbreak, is that we did get some interesting data from how this virus infects people out of that outbreak. There, for example, were instances where we would have outbreaks that lingered longer than normal, and we think that's because this virus established some reservoirs in the human population, which is not normal and not something we usually think about with Ebola virus, like a quiet little STI. And that was primarily how we characterized transmission months after an outbreak was declared over. We would have a case of Ebola pop up in another place, and then transmitted usually through like sexual transmission would be how we would trace that back. And then we'd sequence those viruses, sequence the Ebola viruses that we get from those patients, and do a genetic analysis to see how similar they were. And if they were super similar, then the inference that you make is that there might have been like a direct transmission link between those two outbreaks. So, yeah, there is some weird evidence for persistence with Ebola, but I don't know how common that is. And fortunately, most of these outbreaks are pretty small, like maybe a couple dozen people, not huge outbreaks. Okay, so the next hemorrhagic fever virus is Lassa virus. This is another African hemorrhagic fever virus, but as we saw in that last map, it doesn't have quite the same classic endemicity region as Ebola. It's a little bit farther west. So these are this part of West Africa, this is sort of like the Lassa belt, known as the Lassa belt. There are up to 7 different genetic clades of Lassa in this region. It got its name from this town in northeast Nigeria, the town of Lassa, where like an initial outbreak was characterized in the 1960s, but it's probably been circulating in the human population for hundreds of years. Just hasn't been characterized up until that point. Unlike Ebola, its vector is this cute little rodent called Mystomas natalensis, the multi-mammoth rat. So its region of endemicity corresponds to the region where this rodent circulates. So this pocket in Western Africa and then in Nigeria, primarily. Compared to Ebola, it is considered to be less virulent, fewer mortality rates, more cases that are asymptomatic. But when you have severe disease presentation is really bad too. So you have all the bleeding and hemorrhagic signs you get with Ebola, with those really severe infections. With that, going back to the transmission really quick, with the rodent transmission, this is usually through contact with rodent excreta. When those rodents are infected, they're shedding it from all sorts of tissues. So you can get it from eating the rodents themselves, which is done as a source of bushmeat, or just rodents coming in and out of houses because they're not sealed houses. So rodents come in and you accidentally ingest or inhale their excreta that way. Person-to-person transmission is possible, but it's not as easy as Ebola virus, so it's harder to transmit Lassa virus person-to-person. With healthcare settings, we had a couple documented cases where Lassa was transmitted to healthcare workers. One very high-profile instance with an autopsy was transmitted to pathologists performing the post-mortem exam. That was in the 1960s when they evac'd a missionary, one of those U.S. missionaries that was in Nigeria, who got killed, and her body was taken back to New Haven, Connecticut. So some pathologists at Yale could determine what the cause of death was. Those pathologists ended up getting infected, and they actually died. So we had our first deaths due to Lassa virus in U.S. soil due to an autopsy. Stuff like that, when that happens, that forces us to change the way we handle infectious disease cases, especially when they're import cases. So we had to codify biosafety regulations after that. It just changed the way we handled import cases. All right, in terms of disease, like I said, very much the same. Initial prodromal, flu-like onset, progressed more severe disease, looks an awful lot like Ebola. Nothing really distinctive here, nothing that Ebola couldn't cause. Here's a picture of some patients who have some Conjunctivitis, looks like they're starting to bleed a little bit through the mucosa near the eyes. Death is usually due to multi-organ failure. Necrosis in the liver and spleen is a defining feature. For survivors, we have some sequelae that are associated with loss of virus. A lot of them are the same, but in particular, hearing loss is probably the number one most prominent sequela associated with loss of virus survivors. About a third of hearing loss cases in West Africa, those endemic parts of West Africa, are due to survivors with loss of fever. So this happens a lot. There's estimates of about up to 300,000 infections per year. A lot of those are asymptomatic, but you can be asymptomatically infected, recover, and still have hearing loss problems. And for that reason, that's why you have such an association of hearing loss in those regions and loss of infection. Diagnosis, same, can't really do it based on clinical suspicion. At this point, when it's really severe, the most you probably know is that you're dealing with a hemorrhagic fever virus, and if you're in one of those Western countries, certainly Lassa would be in the differential diagnosis, but you still need PCR or you still need serology to confirm those diagnoses. Quick little case report. We've had about 8 import cases of Lassa into the United States. This was the last one that happened a decade ago, although I think last year there might have been a case that's not very well described, an import case that happened in Iowa. But this one was extremely well described, and there's also a link if you want to read more about this particular case. But there involved a guy who was traveling from Monrovia in Nigeria to JFK through Morocco. And when he left, and mind you, this is in 2015, so this is on the tail end of that big Ebola outbreak, which was really affecting travel from Africa at the time. I was still living in Africa at that time too, and I can tell you it was hard to get out of Africa then. Anyway, this guy was not symptomatic or febrile. He didn't have a fever when he left Liberia, but when he arrived at JFK, he had this triad of symptoms, which may or may not be important, right? He had a sore throat, he was feverish, and he was tired. Coming off a big international flight, maybe that's not such a big deal, depends how severe it is. But it was severe enough for him to seek medical attention. So the day after his flight, he went to a hospital in New Jersey. He was sent home and had a normal temperature. So if this was due to Lassa virus, then he was febrile on the 18th and not febrile on the 19th and 20th, which is really hard. If you can imagine yourself working at an emergency department and seeing a patient like this, I can totally understand how they would send him home. But if he appeared to be in good health, then you wouldn't really think anything of it. However, 72 hours later, he had symptoms bad enough where they were probably at that point suspecting he had hemorrhagic fever. So he was transferred to a hospital that was equipped, had biocontainment, and was equipped to handle hemorrhagic fevers. So very, very ill probably. At that time, he probably knew that he had just gotten off a plane from Liberia, an endemic country. They took specimens, they submitted them for testing. The results came back positive on the 25th, which was the day that he died in isolation. So that entire course from the time that he left Liberia on the 17th to the time he died on the 25th was about an 8-day period. Fortunately, wherever he was treated, which was not disclosed in that CDC publication, was able to contain that infection. There were no secondary transmissions, so he died in isolation. But it just kind of shows you a couple things. One, travel history was not known. 2, he went on a flight with one of these hemorrhagic fever viruses from West Africa. And that is something that kind of you need to keep in mind as a possibility that you might be seeing patients with travel history who have these general non-specific symptoms, early symptoms. Okay, the Bunya viruses. This is an order of viruses, has a bunch of different important members. As we go through the Bunya viruses, not all of them are capable of causing hemorrhagic fever, but of the ones that are, the big ones are Crimean Congo hemorrhagic fever and Rift Valley fever. One of the hantaviruses can do that as well. This is hantavirus fever and renal syndrome hantavirus. The other type of hantavirus cannot cause hemorrhagic fever. We're not gonna talk about lacrosse virus, but that's an encephalitis virus, so it's not associated with hemorrhage at all, it just causes encephalitis. For CCHF and Rift Valley fever, these are vector-borne diseases. Crimean Congo hemorrhagic fever is transmitted by ticks, and Rift Valley is transmitted by mosquitoes, specifically Aedes mosquitoes. With hantaviruses, like the hemorrhagic fever with renal syndrome hantavirus, that is unusual in that it's transmitted and maintained in rodent populations. So you get it much the same way that you would get Lassa virus. Come into contact with rodents, you can inhale their excreta, and you can get hantavirus that way. In terms of pathology for the hemorrhagic fever viruses, once you get exposure, these oftentimes have tropism for your endothelial cells. With I hate this acronym, it's one of the worst virus names of all time. HFRS, with this one because it's a renal syndrome, renal virus. It has tropism for the kidneys. CCHF has tropism for the liver, it can cause direct liver damage. And then a virus like lacrosse encephalitis virus has tropism for the CNS. That's how you get encephalitis with that virus. So different viruses, different tropisms. Prevention, again, depends on just knowing which virus you're talking about. If it's an arthropod-borne virus, you have to encourage the use of these protection measures against arthropods. And for rodent-borne diseases in areas where these are common and prevalent, people need to know ways of protecting their homes from rodent exposure. Question for you guys, true or false?
Yep.
Do we have any endemic hantavirus diseases in the United States? We do. Okay, which ones? Hantavirus pulmonary syndrome. Yep. Nombre. Yes, we do. So, do you know which region of the United States that you're associated with? Southwest, Four Corners region. All right. What's that? Oh, cool. Right on.
Didn't Gene Hackman's wife die from that?
Yeah. So that was what, like 4 months ago, because I remember talking about, I think her name was Betsy, I forget what her last name was, but that was 4 months ago. I was lecturing about that last time. It corresponded with when we were talking about Synombre virus and hantaviruses in Block 4. So, like exceedingly rare, very, very pathogenic virulent virus, and the celebrity's wife got infected with a fatal infection of hantavirus pulmonary syndrome, HPS, in the Four Corners region. I think their house was in New Mexico. So. Santa Fe. That's right. I saw like pictures of their house, this beautiful mansion. Yeah.
They don't have a house like that in Illinois.
Yeah. And where are you from? Which state?
Like the New Mexico parts.
Oh, okay. Cool. Okay, so you guys you talk about this number all the time.
Yeah, it was a bunch of public health stuff about it.
Okay.
You're gonna be out there cleaning out stuff with a lot of rodent urine in it, like wear masks.
Yeah.
Make sure you pick your safety glasses and whatnot, but COVID,
Transmission, yeah. In areas of endemicity, like educating the population on how to avoid contracting this is key. So somebody in Massachusetts may never heard of Synombre virus, but Four Corners region people. Okay, so we'll talk about CCHF first. Again, it's a Boonia virus. As the name suggests, it has a pretty wide geographic distribution, but it's not in the New World, so not in the Western Hemisphere. This is more of a old world virus, if you will. Tick-borne transmission, this is one of the genera of ticks that can transmit CCHF. It's not the only one, but it's Hyaloma tick species, or tick genus, that is also endemic in large parts of Asia and Africa and in the Middle East as well. It is a reservoir for this virus as well as a vector for it, so it transmits and maintains CCHF. In terms of transmission, we can get it primarily through exposure to these ticks, or because these ticks feed on livestock that we come in contact with or other animals, we can get it through contact with the infected animals. It is possible to get person-to-person transmission, and for that reason, if you have patients with CCHF, they usually are under containment, so you don't get transmission, but this is not an efficient way of transmitting the virus from person to person. It is harder to, you still have to be careful though. In terms of symptoms, same, very sudden onset, kind of generic symptoms, but when progression occurs, remember I said it has some tropism for the liver, so you might get some symptoms of jaundice, icteric symptoms, some neurologic symptoms, some mood changes, and then hemorrhage. Relatively small percentage of cases progress to hemorrhage, but here's some photos that kind of show evidence of severe hemorrhage in patients. This guy on the top is a patient in Turkey. We talked about petechia being those like pinpoints, little dots on the skin that shows capillary breakage. They get bigger than that, those are called purpura, and when they start coalescing, this is called ecchymosis, why it's real bruising on the skin like this. This is a woman in Iran, which is another endemic area for CCHF. And you can see how extensive the ecchymosis is in her extremities, in her legs and her arms. With severe cases, hospitalized patients' mortality can range anywhere from 9 to 50%. Pretty high CFR there. And the diagnosis is the same as we've talked about for other hemorrhagic fevers. If you know tick exposure, that would be significant as well. Tick exposure. Rift Valley fever, I mentioned that was transmitted by, that's mosquito-borne disease by Aedes mosquitoes. It too, yes sir.
So is it safe to say that the temperature still internal then? Those vignettes and all those stuff, we have the ecologic.
I don't know if those two pictures would be representative for whether or not you can get external signs of hemorrhage. I can look into it and see if there's hemorrhage. I think the number of cases that result in hemorrhage, even fatal cases, is generally smaller and lower than Ebola though, so I don't know how often that happens. Okay, with Rift Valley fever, this is a particularly difficult disease to diagnose. A very small percentage of cases, less than 1% of cases, progress to hemorrhagic fever. So you more than likely will not see hemorrhagic fever with Rift Valley fever. Ditto with encephalitis, less than 1% of patients get encephalitis. The most pronounced severe form of Rift Valley fever is this ocular disease, where even that is about 10% of patients. So most people who get Rift Valley fever, we'll talk about the region of endemicity in a second, will have either very mild symptoms or be asymptomatic altogether. As I said, primary exposure through mosquito bites, but because these mosquitoes bite livestock, animals, domesticated animals, these animals can become infectious sources for us too. I don't know what I originally have written there, but that should be direct exposure to infected animals. With this sheep that we're looking at here, this isn't like it's just some random awkward sheep photo. What you're seeing there is an infected sheep with Rift Valley fever that is giving birth to a stillborn birth. So that's common. It causes a lot of abortions in these livestock animals. It causes significant disease in livestock animals. All right, endemicity for CCHF and Rift Valley fever. Crimean Congo hemorrhagic fever. The first cases were almost simultaneously characterized, with one of them being in Ukraine, Crimean Peninsula, and the other being down in the DRC, deep in the Congo. So since then, the range for CCHF has broadened out considerably. We get cases as far east as China, sometimes Mongolia, CCHF. And notably also, we get cases of CCHF in Europe. So if you go to USACOM, this I just pulled from this week's AHSD report. They had a case of Crimean Congo hemorrhagic fever in Madrid this week, or maybe it was at the end of last week on the 17th. So that's all the way in Western Europe and Spain, they have a case. So cases are starting to increase up around the Mediterranean basin and up deep into the Black Sea region. This was a disease we did heavy surveillance for in my last assignment in Georgia. We're trying to find, we're doing tick drugs, looking for CCHF Eurasian ticks. I didn't find any, but we did have an outbreak the summer before I came to Texas where we had 40 people in Georgia with CCHF. It was a bad year for CCHF. For Rift Valley, there is some overlap geographically, but the Rift Valley is a geographic part of Africa that's about 7,000 kilometers long. It stretches from Egypt all the way down to northern Mozambique. So a lot of countries affected with Rift Valley fever, very few cases are that severe. Just remember, different vectors, mosquito for Rift Valley, tick for CCHF, and a bigger endemicity zone for CCHF. And both of these are old world diseases, so we don't have them in the Western Hemisphere. Yeah, why don't we take a break and come back at 11 o'clock and we'll pick up the controversies.
So I have read. Is that something virus, magic virus, done? Is that something just?
We would work, so we're, in terms of severe diseases, areas that are most consequential, parasite, and we are talking about controlling usage of mosquitoes in US states like Texas and Florida, right? But that's for a different problem, a different disease problem. Hemorrhagic fevers, really the only one we're talking about is the Rift Valley, and that is not a big concern.
Not worth it.
It's not worth it. I mean, Ebola is by far what we put most of our efforts into because we are now acutely aware, we appreciate the fact that we get transmission cases of this. Because we put all of this into we look into 5 different facilities across the US and people will respond to that disease. It's not like we go out there and try to eradicate reservoir species now.
Sure, so we're not killing all the bats.
No, we're not.
It's like nuking a hurricane, alright? It's not
like-
worth it.
Yeah, it's the same mentality.
Fair enough, kill all the bats.
We need that.
We need mosquitoes. We don't need.
We need bats to kill mosquitoes.
Yeah, we don't need mosquitoes, we need bees.
We do need mosquitoes.
We need bees.
Mosquitoes pollinate our crops.
So mosquitoes are bees.
All mosquitoes, but I mean, what is pollination? It's now mosquitoes play a huge role in pollinating crops. So if we eradicate, people are like, oh, let's just eradicate all the 80 tulip species of mosquitoes. That would throw us into a disaster.
Think so?
Yeah.
Or is that like theoretical?
All upside, no downside.
I mean,
I tell you what,
just make more bees.
yeah, I'm not against that idea, you need to bring back bee population, save the honeybee, right? But, we should separately research that question and see what the thinking is, the current thinking on the consequences of eradicating multiple genera of disease-causing mosquitoes, like Aedes and like Cleis.
I mean, they're all about kind of eradicating them. Sterile ones from the stratosphere, they don't care.
That's what we were just talking about, like, those wildfire mosquitoes that cannot breed, that is supposed to be like single cycle, so we don't have like long-term effects.
I thought it was actually supposed to like give you second generation, so they reproduce their offspring back.
That might be a little bit behind that, but I don't think it's intended to be permanent so decimate the population. Desperately want to bring that value into this conversation.
Yeah, we'll have to ask these anyway.
You know, when they slide,
Yeah, I mean, but that needs a break from this class.
My head, I forgot my headphones.
72. We have 72 steps. Or from the very bottom. I think it's 72 steps. Yeah, we go like that. Nine up and down, or like nine. It's a stand. It was like 10 minutes.
And like by the end of the movie, you gotta start like a booty game. Not a good
I don't know, man.
One thing I like to invest in there is the way like if you want to
I know exactly.
you're looking at
I had to get that out of my head.
$500, but it's up to like 75 pounds.
I fall asleep. If I could, I would fall asleep. What I want is one of those ones with swan wraps. You see those ones, they were trapped down. Or down, you're gonna do weights on your arm and yeah. I wonder if I work out more or not. I know, right? I know some people work out less than they have do me? Could be. I think I would be inclined to do more. I'm a night do you realize how hot it is? Well, in rain. He's still right at temperature. He's like this. They say like the class before me at Arizona. So we were sitting there waiting to go inside the schoolhouse, and the class before us was finishing up. They started. I think they had like and guys were coming across the finish line and like screaming behind us. Grab him, trying to take down take him back to whatever. And we were all like,
We just finished talking about some Brunia viruses, and now we were talking about hantaviruses. When we're talking about hantaviruses, we're also talking about either Old World or New World hantaviruses. The one that's associated with hemorrhagic disease, those are the Old World hantaviruses. So we don't get, with few exceptions, cases of hantavirus you get in the Western Hemisphere are not going to be associated with this very serious form of hemorrhagic fever with renal syndrome viruses that you get. Those are mostly endemic in wide swaths of Asia and Europe. They too are vectored by rodents. We have multiple different species of, or different types of viruses that can vector this disease. Hantan, Nebrava, Sarema, Mala, and Sol viruses. Each one of those viruses that I just rattled off for the Old World hantaviruses is associated with a different rodent vector in a different region of endemicity. Most of the diseases we've been talking about are in the tropics, the tropical regions of the world, but these are kind of an exception. Hantan, which is probably the most severe out of these 5 viruses, is endemic in Japan, China, Korea, so in East Asia. Nebrava is a virus that's more in the Balkans, so Southeast Europe. Sarema is Finland and Russia. Mala, that might be Finnish Estonian, so both of these are like Scandinavian viruses, Eastern Scandinavian viruses. And then Sol. Sol is the only one that you could consider to be a cosmopolitan virus. It does get around, and that's because it's vectored by the common rat, which can get on ships and cause outbreaks in port cities worldwide. So we've had cases of Sol hantavirus hemorrhagic fever in the United States, in California, for example, associated with carriage by rats on ships, cargo ships. In terms of its clinical presentation, it is, when it's very severe, another hemorrhagic fever virus, but notable is the kidney damage that you get associated with these infections, which gives its name. Transmission is usually inhalation of aerosolized droplets. I don't know if this has even been documented, rarely, if ever, person to person, if that's theoretical or whether it's been documented, but that's not considered to be a significant source of transmission at any rate. Symptomatic period within a week or two, early prodromal symptoms with notable vision problems, blurred vision, redness of the eyes, and then progression to these really severe symptoms associated with hemorrhagic fever, low blood pressure, shock, vascular leakage, and then the kidney damage that can occur as well. As with the others, geography plays a big role in diagnosing this, as well as PCR and serology. The New World hantaviruses are associated with Hanta pulmonary syndrome, HPS. These symptoms, they begin 1 to 8 weeks after exposure, and when you progress past the general symptoms, the late symptoms that are sort of characteristic for pulmonary syndrome are things that you associate with a lung infection, coughing, shortness of breath, and fluid in the lungs. This is not like some trivial common cold type of situation though. This is a really severe presentation where patients can go into respiratory failure. So significant damage to the lungs. I don't know what the fatality rates are, CFR is for hantavirus pulmonary syndrome, but I know that it is, oh, they're right there. For Andes virus, it is higher usually than Synnumbre virus. And the reason being, it's just a more virulent virus. You don't have cases up here in North America, and you get person-to-person transmission. This is the only hantavirus where that is characterized, well-documented person-to-person transmission with Andes virus. Going back to Synnumbre virus, in terms of the number of cases we have per year, not that bad. It's pretty rare, but 35 to 60% mortality rate is appreciable. In those pockets of the United States where you do get transmission for Synnumbre virus, they tell people that if you have these symptoms of, like these respiratory symptoms, and you have a noted rodent exposure, you should seek medical attention. So I would imagine a very small percentage actually end up being diagnosed as HPS, but that's the medical advice in these regions. We do get cases beyond the Four Corners region, all the way up into Canada occasionally, that are concusses, but most of those are in the Four Corners region. In terms of the name, this virus used to be called Muerto Canyon virus when the initial outbreak happened in 1993, but that happened on a Navajo reservation. The Navajo Nation did not want this virus named after the canyon in their region, so they weren't allowed to name it Muerto Canyon. And at the time in the 90s, we used to name viruses after the place names of where they were first identified. We don't do that anymore. Now we've moved towards naming the viruses more descriptively of the diseases they cause. So you get these really obnoxious long names, but you're no longer stigmatizing the regions where they're first identified. So they shot down naming it Muerto Canyon virus. They proposed naming it Four Corners virus, but the residents of those Four Corner states were like, I'm not gonna do that either. So finally the virology community was like, okay, we'll just call it sin nombre out of frustration. No name, virus with no name. Alright, moving on to a different group of viruses called the flavy viruses. I'm going to be talking about 6 different flavy viruses. The first 2, yellow fever and dengue, are capable of causing hemorrhagic disease. So you can kind of group those in that respect to the viruses that we've been talking about so far. The rest of these are not. Japanese encephalitis viruses causes encephalitis. West Nile causes usually a pretty mild systemic disease. Zika virus also causes systemic disease, fever, arthralgias. And then this last disease is an exception because it is not transmitted by mosquitoes, unlike the previous 5. This is the only one that's transmitted by ticks, and that is called tick-borne encephalitis virus. So pretty easy to figure out what is vectoring it and what it causes just by the name, tick-borne encephalitis virus. With each of these mosquito-borne diseases, where those mosquitoes that vector them are geographically important for where they are, but most of them also have some sort of secondary vertebrate host. So be it a rodent or a bird or some other animal like a pig in the case of Japanese encephalitis virus, pigs can be that secondary vertebrate host. There's usually some sort of other species reservoir that's capable of sustaining those viruses and contributing to their circulation. Since we are mostly focusing on the mosquito-borne flaviviruses, this probably warrants a little bit of discussion on how mosquitoes are actually able to transmit this virus. Most mosquitoes do not live a very long time. The females, the ones that are actually taking the blood meals and biting people, are the ones that are transmitting most of these diseases. And they live significantly longer than the males, but still not very long, like maybe, I don't know, 2 months tops for females. So from the time they take a blood meal from an infected monkey or bird or whatever is carrying that particular virus, to the time they transmit it to a human is usually a fairly short window. So they take their blood meal from an infected host. The virus goes into circulation, it goes into their mid-gut first, and then into their hemolymphatic circulation, which is essentially the same as the circulatory system for mosquitoes. And then you get a little bit of viremia, a little bit of amplification of the virus in that mosquito, and then the virus will tend to concentrate in the salivary glands of the mosquito, so that when it takes its next blood meal, it can inject that high level of virus into that host. The amount of virus that is inoculated into that host is important. So this is somewhat of a dose-dependent thing, but you have to have a high enough amount to actually infect that new host. Once you get these viruses into your circulation, that proboscis, the mosquito, will find a capillary to inject it into your circulation. Those viruses will migrate into whatever tissue they have tropism for. So for the hemorrhagic fever viruses, they'll go into infecting endothelial cells. With yellow fever, there's also a hepatotropism, so it just depends on the virus itself where it goes. We'll talk about yellow fever first, a very historically important virus. Lots of books written about this, lots of information about yellow fever virus, even in the course of US history. If you're interested in medical history of the US, I definitely encourage you to read more about yellow fever virus. But this is a virus that infects a lot of areas in the tropics now. About a century ago, its range used to be a little bit farther north, so we would get cases in the United States. We have plenty of cases in like Texas, Louisiana, the southern US. Not so much anymore, very few cases on US soil, but very prevalent still in South America and in Africa. With people who contract yellow fever after their initial prodromal phase is over, a relatively small percentage of people progress to these severe symptoms. With yellow fever, it will involve symptoms like jaundice, so high fever, yellow skin, other enteric symptoms. If somebody has hemorrhage associated with yellow fever, you can get this characteristic black vomit that's associated with damage to the GI tract. So the virus is causing direct damage. It's causing liver damage. The liver is producing clotting factors, so that causes coagulopathies, and that in turn causes vasculopathies. All of that contributes to GI bleeds. So upper GI bleeds like that, you get the black vomit, like you can see in this picture of a patient in 1892 in Veracruz, Mexico, that's vomiting blood. Very painful way to die, and you can also get like black tarry stools because of the amount of blood that's being released in the GI tract. 30 to 60% mortality rates. There is a vaccine for yellow fever. Probably a good chunk of you in this room have been vaccinated against yellow fever, I would imagine, especially if you've traveled a lot. It's considered to be it's a live attenuated vaccine, and you do get a pretty strong immune response to this after a single dose, so good vaccine. Here's that endemic range, 200,000 illnesses a year. This is a lot of people live in these parts of South America and Africa. Anybody want to take a guess at who that gentleman is in the upper right? Yeah, I heard someone say it. Did you say it? Who said that? You said that? Walter Reed. Okay, very good. Who was Walter Reed?
I know he was a physician in the United States Army, and if I'm not mistaken, it was his research on yellow fever in the Spanish American War that led to the development of the vaccine, or at least being able to figure out these field vectors.
Yeah, pretty good. He's given a lot of credit for his work done on yellow fever. He was a military doc. He was an Army major, I think, was his rank. So around the turn of the century, he was charged with going down to Panama, where we were trying to build the Panama Canal at the time. The French have tried. They've given up because of how bad yellow fever was and other diseases like malaria. It's just decimating the workforce. So they sent this guy down to be in charge of eradication efforts and get this under control. And he's done a lot of work on yellow fever and malaria. He was one of the people who was credited for linking the source of transmission, so linking this to the Aedes mosquitoes that transmit yellow fever virus. There was actually a Cuban epidemiologist named Carlos Finley who made that linkage, that epidemiological linkage 20 years before, but Walter Reed gets most of the credit. So Walter Reed has a research institute named after him, Rare Walter Reed Army Institute of Research, and he also has that huge hospital, the Walter Reed National Military Medical Center, which some of you might go to phase 2 at. So lots of credit given to him. The guy who actually did a lot of the work in terms of mosquito control efforts there, like draining stagnant water, telling people to control stagnant water sources, pouring oil in water that couldn't be drained, all of his efforts to control mosquito populations. His name was William C. Gorgas, and he gets hardly any credit for those interventions in Panama. They did name the library after him at Rare, so like this book that I got from Rare's library, it's stamped Gorgas Memorial Library, just a little bit of irony there. But he became Surgeon General at the time, so I think he was recognized in his life at least. Dengue is the next virus we're going to talk about. This is another flavivirus, and this can also cause hemorrhagic fever. More often than not, it can cause some other symptoms as well. It's associated with shock and some very, very serious health challenges. Very painful disease to get. Notable is the fact that you have 4 serotypes that circulate in different parts of the world. Mosquito-borne disease, serotypes in different parts of the world. Some of them do overlap. And unfortunately, if you get infected with one of these serotypes, not only do you usually not get any protection against the other serotypes, but you get reinfected by a different serotype, sometimes that disease course can be even more severe. So because of that tricky immunology aspect and the different serotypes of dengue, that has made it difficult to develop a good vaccine against dengue. We don't have one in the US, and even if we're traveling to one of those endemic areas for dengue, we don't give it to US travelers. And I think part of the reason is because it does have such a poor track record for protection against the different serotypes that circulate. It's very tricky to do. Going back to the disease presentation, because dengue affects such a huge population, there's a lot of population at risk for dengue, 100 million people. Physicians who see patients who have a fever in those endemic regions usually have dengue very close to the top of the differential. That's how common it is. If they present with a fever, and if they present with a rash, which is also very important for diagnosing dengue, just based on empiric symptoms, then they really start worrying about this particular disease. The pain is considered to be severe, painful headaches, painful eye pain, body aches, and it has this nickname, break bone fever, because of how painful it is for the joints and how painful it is to move when you have dengue fever. Presentation can be a little similar to chikungunya, which we'll talk about in a couple slides when we talk about health viruses, but there are some differences to help discern and break up that differential diagnosis. Let's see, there is a diagnostic test that is useful for dengue, and it's based on the fact that you do get rash presentation, not with all cases, but with a good number of them. The test is called the Almeida test, if you've ever heard of that before, but it basically involves counting the number of petechia on the forearms of somebody who presents with a rash and who has a fever and pain in one of those endemic areas. It's not a super sensitive test, it's not a very specific test, but it's still done. And what you do is put a blood pressure cuff on somebody, their forearm, inflate it to the midpoint between the systolic pressure and the diastolic pressure, so let's just say to around 100. Keep it on there for 5 minutes, and when you remove it, you count the number of remaining petechia in like a square inch of that person's forearm. If the number of petechia are between 10 to 20 petechia in that area, that's considered to be a positive tourniquet test for dengue. In the absence of PCR or serological testing capabilities, that would contribute to a diagnosis of dengue. Here's a very, very wide endemic area. See, it's stretching all the way into Asia and a lot of those islands that are in oceanic countries, oceanic Australasian countries. See some cases kind of edging up right on the US-Mexican border there, right? Do you think the viruses respect international borders between the US and Mexico? Absolutely. No, we do get cases. Out of the cases we get in the United States, the vast majority are going to be import cases, travelers coming up from different parts of the world. However, last year in November of 2024, we did have a pretty high profile case of Arctophanes dengue fever down in Cameron County, that's the southernmost county in Texas. Arctophanes means that you acquire it locally on local soil. So yeah, that was a native acquisition of dengue fever in the United States, kind of a big deal. In terms of things that I've recently pulled from this week's surveillance reports, we've got a couple notable things. These are all coming out like in the Western Hemisphere. But there's a ship that Southcom uses, it's called USNS. The Navy uses this ship for humanitarian and medical assistance reasons. So they do some surveillance work. and they have reported a couple things from last week, 17 July, Panama, 8,000 dengue cases in Panama. In Honduras, over almost 10,000 cases during 2025 so far. And then just on Monday, on the 21st, USNS Comfort reported a surge in dengue cases in Colombia. So Colombia's over here. We've got over 45,000 cases in that surge of dengue in Colombia. Last year in 2024, it was incredible. We had a huge uptick in cases in Brazil. Brazil got walloped last year. But these outbreak years for dengue, it's always pretty bad, but they tend to be really bad every 3 to 5 years. I think last year was just exceedingly bad for dengue cases. 100 million cases a year, that's right out of the murder textbook. It's a lot of cases of dengue. Fortunately, again, like a relatively small percentage will be hemorrhagic fever though. West Nile virus. What do you guys know about West Nile? How many of you have heard of West Nile before? Most people. Okay. So this is a disease that we definitely have in the United States now. It is also mosquito-borne. The mosquito species or genus that transmits it is called Culex, so this is not an Aedes transmitted virus. But it really wasn't on the scene much before 1999. In 1999, we started seeing an outbreak in the Bronx, of all places, at the New York Zoo, and we saw some birds like crows and blue jays starting to get sick. Birds are reservoir species for this particular virus. So from New York State, incidents of this disease, which can be transmitted from birds to mosquitoes to humans and kind of bounce back through this arthropod intermediate vector, we started seeing that spill over into multiple states, and now we have cases of West Nile virus, or West Nile, in most of the 50 states in the United States. A very broad global distribution as well, so it's not just the United States. Leading cause of mosquito-borne disease in CONUS. It's a pretty big statement there. Again, for the way it's maintained, bird populations play a big role in maintaining West Nile virus. Humans are also hosts when those infected mosquitoes bite us. We're susceptible to the disease. Most of the time, these infections are also subclinical or asymptomatic. But when you do progressive disease, you get these general symptoms, sometimes GI involvement, sometimes a rash. Occasionally, in a small percentage of cases, fewer than 1%, you have the neuroinvasive case of West Nile, which we just had, we had one in Texas last year, neuroinvasive case of West Nile. Since this is associated, if somebody does present with neurological symptoms, you can take CSF, you can do a lumbar puncture, take their CSF and do diagnostic tests on their CSF to see if you have IgM, which would indicate an acute infection. This is just last year's data, 2024 in Texas, number of cases we had last year here. Texas leads the country in terms of the cases of West Nile virus disease. We had 36 cases last year. And let's see, Nevada has the second highest case on 23 cases. Some of those, 2 of those cases last year happened here in York County. And that's, one of those 2 was that neuroinvasive disease that I mentioned. In terms of recent headlines, there was the first case of West Nile in New York last week since 2019. And also a West Nile case happening in 7 confirmed cases in Italy. That was this week. Zika virus. This is occasionally linked to encephalitis, not a hemorrhagic fever virus though. Many of the cases caused by Zika virus, another mosquito-transmitted virus, are asymptomatic. Mosquito-borne transmission might be the primary mode of transmission, but what this virus is super famous for is its ability to be transmitted sexually as well. It's the only one of these flaviviruses that can be transmitted sexually, so that's something to really be aware of, that you can have that transmission. And also very famously, mothers who are infected during pregnancy can transmit this virus. It can be transmitted to a fetus and can cause really devastating congenital infections. So the most famous of those congenital infections is shown here in this figure, which shows an infant with a head size that's about a third of the normal, or 2/3 of the size of the normal infant's head. That condition is called microcephaly. Is usually caused when there's damage to those developing neurons when the fetus is developing in utero. And as a result, these infants are born with a much smaller head and usually some neurological defects to go along with it. For adults, so that's the pregnant population and the congenital transmission. For adults who get Zika virus infections, they may get a rash, they might get some joint pain, arthralgias, conjunctivitis, and a headache. Usually this disease will not last more than a week. It has a huge endemic region, including parts of the US. The last big outbreak was in 2017. It was all over the news. You probably heard about this outbreak of Zika because we had cases in the US. Brazil in particular shouldered the highest burden of Zika cases. There were a lot of infants born in that time, during that time period, during that outbreak, who had conditions like microcephaly. But here in the US, we still had a significant number of cases. I'm just scrolling through my notes to see if I can find how many cases we had. So in Brazil, about 3,500 infants were born with microcephaly during that outbreak. You don't hear about Zika circulating much these days, but just from last year's data, there were still 965 Zika cases in 1 month alone. That was in March. So, and a good chunk of them were in Brazil. But US cases during that 2017 outbreak, most of those were imported, but some of them were acquired in the US on US soil. And again, most of those were mosquito transmission. For complications, since this virus can cause neurological problems and infect neurons, these complications are associated with neurological issues. Guillain-Barré syndrome we've talked about before. You guys remember which bacteria are associated with Guillain-Barré? Yeah, I can't even remember, but primarily Campylobacter jejuni. Which one?
We said alien because it has alien in the species.
Alien in the species?
Like the word alien. I don't know what the full species is, but alien.
No one? Really, guys? Just us?
Yeah. I'm super embarrassed, it's a really young one. But Campylobacter is probably the most important one to know with, Psoriasis? Yeah, Psoriasis, okay, my bad. So, those two species in the Campylobacter genus. Anyway, so yes, Guillain-Barré can also be associated with Zika virus as a major complication, and these other two complications, neuropathies and myelitis, also similarly affecting the nervous system. Myelitis is a complication of the spinal cord, so it's kind of like an associated complication you can get. Getting near the very end of the deck, guys, it's done. We got a couple more random ones. First, we'll talk about tick-borne encephalitis virus. I have not been able to find a better slide that doesn't have all these different arboviruses on there, but this will serve our purposes. I'm talking about a tick-borne encephalitis virus where the region where it's predominantly impacting is Europe. This is in Eastern Europe, Western Russia, around there, tick-borne encephalitis virus. There are a couple different serotypes of this virus. There's a species of ticks that transmits it. There are a number of different species. This is another one this is me out in Romania, out in Western Romania, Transylvania. Very sunny, bright, lovely Transylvania. But I was out there doing tick drives, looking for a bunch of different diseases that are transmitted and carried by ticks. And TBE, or Tida, the virus that causes TBE, was one of those pathogens that we really, really wanted to find in tick dregs. But the chances of finding this virus is like a needle in the haystack. We caught a bunch of different ticks, Rhizocephalus, Hyaloma species, a whole bunch of different types of ticks, and would test them for these viruses. Never did find tick-borne encephalitis virus. But those are the regions where it's endemic all across Eastern Europe. And it's important for military reasons, at least in USACOM, because if you've been to that region, you might be aware of the controversy with, like, how we're gonna go about vaccinating people now that there is a vaccine available for tick-borne encephalitis. Who pays for it, how many service members are gonna get it, which branches get it. So that was kind of the entire discussion around TDAV, is whether, like, funding discussions and how to vaccinate people. Anybody ever get the vaccine for TDAV? How old are you guys? Okay. Yeah, that's a 3-dose vaccine. To go back, I got 2 out of the 3 doses and then didn't get the 3rd one, but I don't think that's gonna impact protection too much. Okay, so the other flavivirus is Japanese encephalitis virus. This is important to know because this is a virus that, you know, affects people who are in Eastern Asia, Japan, China, and Korea. You've probably been vaccinated against Japanese encephalitis virus if you've been over to Korea. Good vaccine. Just pulled this cases in India, Japanese encephalitis virus, 2 deaths. As the name suggests, also an encephalitis virus, associated with encephalitis. That's all you guys need to be able to do is associated with encephalitis. And then rounding out the end of these viruses, we have the rotaviruses. This is a genus that has 2 different families that are important to know. The rotavirus family has German measles or rubella virus in it, and that we'll talk about tomorrow. But the one we're going to talk about today is this family called alphaviruses. So alphaviruses are primarily arboviruses. I don't think I've asked you guys this. I've thrown around that word a couple times, arbovirus. What does arbovirus mean?
Tree.
From the Latin arbolis, maybe, trees? It's a good guess, but it's not right. Arbo, do you know, Phil? Arthropod-borne, yes, so arboviruses are, good job. Yeah, arthropod-borne viruses. Yeah, your reward. Most of these viruses all of these viruses we're going to talk about with the alphaviruses are mosquito transmitted. They all have their unique, distinct ecologies and ecological animal reservoirs to maintain it. Chikungunya, it can infect monkeys as well, so it can use monkeys as an animal reservoir population. But because of how many people are in these zones, it really mostly has a human reservoir at this point in time. So when you think of chikungunya, it's mostly human, but they can also infect monkeys. With these other viruses, the so-called B viruses, the name is really descriptive as well. So they all cause encephalitis, but the first E in those is equine. So they infect equine species, horses, donkeys, burros, mules, and they are considered to be enzootic in those animal populations. They can cause devastating outbreaks in horses. The way this works is mosquitoes bite those horses that are infected, and then it will go on to infect humans. Humans cannot transmit this virus person to person, so it's always requiring that mosquito intermediate invertebrate host for transmission. With these encephalitis viruses, in terms of symptomology and presentation, chikungunya is distinctive because it causes really terrible arthralgias. But with the E viruses, those are associated with encephalitis, right built into the name. So remember that they're associated with encephalitis and not arthralgias. And then lastly, with V, V, and E, I don't think I mentioned this, but the W is for, I'm sorry, it says West Nile. It should just be Western equine encephalitis virus. I will fix that. For E, that's Eastern equine encephalitis virus, and for V, that's Venezuelan equine encephalitis virus. So for the Western cases, we haven't had a case of Western equine encephalitis virus in the United States in about 20 years. It's pretty rare. But when we did, those last cases were west of the Mississippi. For Eastern, we do still get cases of Eastern equine encephalitis virus, so those are east of Mississippi. And for Venezuelan equine encephalitis virus, I don't know if we get any cases in the United States. Most of those are gonna be down in Central America and South America. This is a nice figure, but it's a little bit confusing. It groups both some of the flaviviruses that we've talked about and the alpha viruses. But it's a good thing to study when you're trying to understand transmission and ecology of these different viruses. For viruses that rely pretty much just on human to mosquito transmission, we're talking about dengue and Zika. Chikungunya, we just talked about, also has a monkey reservoir population, as does dengue. These are a little bit more complicated. These Sylvatic viruses, they maintained almost exclusively these small mammal hosts, these vertebrate hosts. That would be things like West Nile or Nile fever, where humans are sort of occasionally implicated in transmission. And then the E viruses that we just talked about, where horses play a big role in maintaining those viruses as a vertebrate host for those virus populations. The pig, I'm not really sure why that pig is on here unless it's referring to Japanese encephalitis virus, but none of the E viruses that I'm aware of are transmitted by pigs or wild boars or other swine species like that. So chikungunya, the reason why this is on the yellow fever map for endemicity is because it basically has the same region of endemicity. Some cases are getting farther out into the Indian, like countries in the Indian Ocean and Malaysia and Indonesia over here. But it does cause a lot of illnesses, over 1 million cases a year. Some of those are in the Western Hemisphere. I don't think we get cases of chikungunya in the United States. This is mostly in Central and South America, in the Western Hemisphere. In terms of the illness it causes, you can think about it as very similar to dengue. You might get systemic presentation and a fever. But the difference with this and dengue is you usually don't have that severe hemorrhagic presentation, and people usually do not get shock. But that said, otherwise, it's still a very painful disease when you get arthralgia. The name chikungunya is taken from a Swahili word that means that which bends, and that's a reference to how much pain it causes in the joints, excruciating pain in the joints. After you clear the infection or resolve it, sometimes people have long-term sequelae where they have joint pain that they have to live with. So that's another considerable sequelae for chikungunya infections. Recently, we've had cases in the last week or so reported in China and in Macau. That's so that's pretty far away from that normal range of endemicity, pretty widespread range. Going back to the encephalitis viruses, the alpha virus viruses, and the B's, this is their range of endemicity. Like I said, west of the Mississippi, eastern and east of the Mississippi, and then here's Venezuela for B. As a biological weapon,
Are these names for these viruses and even bacteria for that matter, are they like pretty universal worldwide, or like do different regions of, I guess, like the world call them different things?
That's a great question. So like chikungunya, for example, what Swahili word, it was given for cases that happened initially in East Africa. The ICIC, the International Committee on the Taxonomy of Viruses, when they adapt a name officially, that's the name that is used internationally and forever. So like SARS-CoV-2, that's the international name. Ebola, unfortunately, it's stuck with that name, even though, like I said, we veered off of place names. The reason why we didn't name SARS-CoV-2 Wuhan virus was because of sensitivity out of respect for people living in Wuhan, China, right? But to answer your question, yes, those are the internationally recognized names. If they have any nicknames like breakbone fever or something like that, that's not an internationally recognized name. But chikungunya definitely is. And EUV and V, those are the internationally recognized names for these viruses. What do I want to say about these? So V is the most important of these alpha viruses, alpha arboviruses to know, and that's because it has been researched as a biological weapon. We here in the United States investigated it in the 60s. We had to destroy our stockpiles of it. But the reason being was that its use was rather specific. I brought my USAMR book of biological casualties, but the section on the, on Venezuelan equine encephalitis virus is really interesting because it details why it was developed as a biological weapon and the fact that it can be kind of masked with these natural transmissions from horse populations to human populations. So it'd be hard to identify it as a biological weapon. You could use it kind of surreptitiously and very sneakily. Interesting stuff. And then in terms of mortality, it has a very low mortality rate, but it doesn't affect a lot of people. It can cause encephalitis, like the name suggests, but that's in a pretty low percentage of people. Most of the people get infected with a virus like B, Venezuelan equine encephalitis virus, will get like really severe headaches and will be racked out, like not mission capable, for example, but will not cause a lot of fatalities, which could be desirable for some intents if it's used for those purposes. Yeah, just one quick note on the case of St. Louis encephalitis virus. That's a flavivirus. Since it's on this map, I thought I would mention it. And that was a case that happened in California. Oh, I'm sorry, that's not a case at all. It was just some surveillance where we identified it in a county in California. Alright, and then last slide is just kind of a slide for you guys to study off of. But when you're studying some of these viruses, keep in mind that all of them that we've talked about can cause homicidal symptoms in the prodromal phase especially, and some of them resolve without ever progressing into something that would be more clinically or diagnostically helpful. But with dengue and yellow fever, remember those are capable of causing hemorrhagic symptoms. With yellow fever in particular, that can cause hepatitis, but dengue as well as cause liver damage. You can also get shock with these viruses, particularly dengue. None of these other viruses on this list can cause hemorrhage or hepatitis or shock. They're not closely associated with those symptoms. But for the encephalitis viruses, if it has encephalitis in the name, know that it causes encephalitis. Easy way to study. St. Louis encephalitis, West Nile encephalitis, Eastern, Western, Venezuelan, Japanese, depending on the place name. What else? I've talked about this a couple times, but knowing where you are if you're traveling or where your patients have been, if they're coming back from an appointment or a trip, and they have a fever, feeds heavily into that differential diagnosis. And then if they have the specific clinical features, that will help a lot too. If they have a rash on their skin or something like that, it can help start whittling down those differential diagnoses that start off very broadly. But if you ever want to get a specific definitive diagnosis, you know that you're going to have to use PCS or serology to get those definitive diagnoses. Any questions for today? Okay guys, I will see you tomorrow at I think 10 o'clock also. Okay, alright, thanks guys, I will see you tomorrow.